My name is Lauren DeHost, and this is my capstone presentation regarding reducing the incidence of ventilator-associated pneumonia. Ventilator-associated pneumonia, also known as VAP, is a hospital-acquired infection similar to that of a CAUTI, a catheter-associated urinary tract infection, or a CLABSI, a central line-associated bloodstream infection. This hospital-acquired infection is caused by bacteria introduced during mechanical ventilation. VAP can be prevented using the VAP prevention bundle, which is an evidence-based set of interventions to help prevent this problem. These interventions include maintaining endotracheal tube cuff pressure, keeping the head of the bed at least 30 degrees, and frequent mouth care and suctioning. U.S. incidence of VAP is 2 to 16 episodes per 1,000 ventilator days. VAP has a big impact on our patients. VAP causes increased mortality rates for ventilated patients. The average mortality rate is 50%, which is a very poor prognosis for our patients. It increases the average length of stay by at least 7 days. It also increases the average cost of hospitalization by $40,000 US. Here I did a literature review to support my research proposal. A study in New Delhi, India in 2018 comprised of 60 ICU nurses studied demographic variables and VAP bundle compliance. Level of experience, education, and in-service education were the chosen variables. Knowledge was also tested, which showed a score of 60 to 70%, which was very poor in all of these hospitals, and no correlation was found between VAP bundle compliance and the variables chosen in the study. A 2016 study conducted in Greece followed 362 intubated patients. Staff education over the VAP bundle was implemented over 2 years' time. Handouts, leaflets, posters, and staff lectures were all implemented as the intervention in this study. Results demonstrated increased bundle compliance, reduced VAP incidence, and decreased length of stay after the in-service education was completed. A 2018 study was conducted in Chennai, India, which researched VAP bundle compliance after the implementation of a VAP educational program. After the implementation of the program, in the post-intervention phase, compliance increased to 94% from a previous 89.4%. The study recommended further need for VAP education. A 2015 study was conducted in Egypt, which investigated implementing in-service education to reduce VAP rate in their neonatal intensive care unit. So this is a little bit different than the other studies with it being a neonatal intensive care unit rather than a regular adult intensive care unit. In the post-intervention phase, days of mechanical ventilation decreased, and then VAP incidence rate decreased from 67.8% to 38.2% in this study. In 2015, in Beirut, Lebanon, a study was conducted to examine the relationship between level of experience, VAP rate, and in-service education. A training session was conducted with a demonstration of the VAP bundle and all of its interventions. Bundle compliance significantly increased after the training session in this program. And here is the basis for my research proposal, my PICO question. Annual ventilator-associated pneumonia education for ICU nurses may decrease the incidence of VAP in intubated patients compared to no annual education. The idea for this research project came after I noticed a lack of VAP education in my own workplace. I was required to complete this VAP bundle every 2 hours, but I was never formally trained on the VAP bundle. I thought maybe if our nurses were formally trained yearly, we may increase bundle compliance and therefore decrease VAP incidence in our own hospital. The theoretical framework for this research proposal is based on Benner's novice to expert theory. This is a nursing theory which focuses on a model for the stages of clinical competence for nursing. Benner said that nurses gain knowledge and experience by increased education and experience. Here is the design, the setting, and the sample of this research proposal. The design of this research would take an experimental approach with both control and experimental groups. Half of the ICU nurses on a 30-bed intensive care unit in southern Indiana would be educated, the other half would not. Incidence rate would be collected pre-in-service education at the 6-month mark and again at the 1-year mark post-intervention. The sample population needs to be as many ventilated patients as possible, but this population is based on exclusion criteria, such as all of these patients are 18 years or older, they're not pregnant, they don't have a previous diagnosis of pneumonia. And then participants' rights and confidentiality would be protected by HIPAA. These patients also can't consent for themselves due to being under narcotics and sedatives, so their next of kin would be educated on the research and then they would sign consent. And then the nurses participating in the study would be educated and then asked to sign a consent form as well. And here is the data collection and analysis. VAP incidence rate is the instrument of data collection in this research proposal. It is valid because it's an objective measurement, and it's also reliable because VAP incidence rate is calculated the same way each time. In one of the previous studies, a chi-square test was used to analyze the significance of the same type of data, and therefore I would use a chi-square test to analyze the data for my study. And in conclusion, VAP is a hospital-acquired infection that greatly reduces favorable outcomes for our patients. These patients have a really poor prognosis and increased mortality rate. They stay in the hospital a lot longer, and they also incur increased hospitalization costs. Implementing annual mandatory education for these patients or for our nurses may greatly improve patient outcomes for these intubated patients. And that is it. Thank you.